So, without further delay, let's jump into the topic. And today's objective will be defining agitation and aggression. Want to know what are all the different types of and the forms of aggression. We'll acknowledge the risk factors associated with aggression and how we can prevent and manage aggression. So, any individual who is getting into the healthcare system are often in great distress. So they are in a mindset like where so much of emotions are undergoing in them. They are psychologically and physically discomfort, like they are having some pain, fear of unknown, sick, tired. So how they are responding to the events, they will be responding with some kind of anger or fear, or with the perception of not being respected or not being listened to or being treated unfairly. So there is always some kind of frustration and varied emotions. So these can pose a risk to themselves, others, other patients, or the healthcare provider. And often there is a more chance for them to get agitated or aggressive. So the word aggression, agitation, violence are all used interchangeably. So we would like to know about the difference between agitation and aggression. So usually agitation is a precursor of aggression. So agitation is defined as a state of excessive psychomotor activity accompanied by increased tension and irritability. This is the DSM-5 definition for agitation. In simple, like what it says is agitation is an emotional distress combined with increased activity. And how will you know when a patient is agitated? There are some signs which they exhibit, and it is important for us to know what are all like some signs of agitation. So, which includes pacing, wandering, yelling, help seeking. Sometimes they come to the desk, like nursing station, so often asking for information. So they are seeking help, which tells us they are agitated. And they repeat like the verbalization. You have to like tell them like whatever you are trying to say to them, like repeatedly. And they are restless, and sometimes they will be more demanding. So, how will you respond to this agitated patients? So, remove them from the stressful or overstimulating situation. Try to distract them with conversation or a task, a music, or familiar object or food. Check for any kind of discomfort, like they are in pain or they need to go and use the washroom. Attend to their basic need, like are they hungry? Pay attention to that and speak softly. Use familiar words and short, simple sentences. We don't want them, first of all, to be agitated. So, how can we prevent that? So, identify the triggers, like what will put them at risk for developing into that agitated state, and try to avoid that or satisfy. Frequent, brief, reassuring contacts are important, and avoid complex tasks. Sometimes, if you give complex tasks, they get easily frustrated. There comes the anger with frustration. So, these are all like the slides which I have been talking about. Apparently, sorry, I apologize, like you were not able to see the slide. Can you see the agitation slide right now? So these are like, as I talked about, like we saw some of the signs of agitation, like pacing, wandering, yelling, help seeking, and shadowing, repetitive verbalizations, restlessness, and demanding. So we also talked about how we respond to agitation, like remove the person from the stressful situation or the overstimulating situation, distract them with conversation or a task, music, familiar object, or food. Check whether they're having any kind of discomfort. Attend to their basic need and speak softly using familiar words and short, simple sentences. We also talked about how we can prevent agitation. So, by identifying the triggers and to avoid or satisfy, having frequent, brief, reassuring contacts, and avoiding complex tasks with that, and having established predictable routine. Rest is also important in an acute inpatient unit. Make sure you are scheduling adequate rest and soothing environment in the room. So if you have like a crowded area or a noisy situation, that also can cause agitation. So providing a soothing environment is also important. And never ever rush. Now, so far we have seen about what is agitation. Now we will move on. And we discussed agitation is a precursor of aggression. Now we will move on to what actually is aggression or violence. So, according to WHO, the word aggression and violence are used interchangeably, and the definition is the intentional use of physical force or power, threatened or actual against oneself, another person, or against a group of community that either results in or as a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. The word aggression actually originated from the Latin word aggredi, which means to approach or to attack. In simple words, like what the definition says is it's a hostile action directed towards a person, self, or object. Now we will move on to like what are all the different types of aggression. Basically, aggression can be broadly divided into two categories. One is impulsive aggression or emotional aggression that basically stem directly from the word emotions you experience in the moment. Here, the goal is to cause harm or injury to another person. So, for example, if if you cannot access the thing or the person or someone is upsetting you, then you may redirect the aggression towards the person or the object. That's an example for an impulsive or emotional aggression. Basically, if a teenager gets insulted by the comment of another person, he's going to fight. So, whereas in cognitive or instrumental aggression, what's happening is it involves planning and intent, typically to achieve a specific desire or goal. The goal is to achieve something. Uh, it has some calculation or purpose without loss of control. In, for example, a murderer killing someone for money or revenge, or a terrorist bombing a building. So these are all like some of the examples which we can give for cognitive or instrumental type of aggression. So now we have seen what are the basic types. Let's see what are all the forms of aggression. So how aggression is exhibited. So basically, aggression is exhibited by physical, verbal, passive, relational, and hostile. These are all like some of the forms how it gets uh, expressed. So physical aggression includes hitting, kicking, punching, slapping, or any acts that cause some physical hurt. Whereas verbal aggression, you may all know that it includes shouting, swearing, insult, or passing some unkind remarks which cause some pain and distress. Passive aggression. So that includes any indirect expression of negative feelings. So, for example, passing some sarcastic remarks, redirecting the blame, procrastinating, or failing to complete a task. The other forms of aggression are relational and hostile. So, in relational aggression, it refers to the actions aimed at damaging another person's reputation or relationship, for like gossiping, bullying, those kind of actions. And in hostile, as the name suggests, it describes an emotional or reactive act, like vandalism. So the main intent is to hurt someone or destroy something. Now we will move on to a study, scientific study. So the main purpose of this study was to compile a complete overview of the available knowledge on factors that contributed to the development of aggression on a general psychiatric admission ward. So this take it into account like the studies from 1999 to 2019. So basically they compiled and they came into conclusion like there are uh, three different factors which are associated with the development of aggression, and those factors are patient related factors, staff related factors, and environmental related factors. So it's an interplay between these three factors. Prediction of aggression is multifactorial, and in this some risk factors are dynamic in nature and they are interactive, like in the current ward situation, whereas others are stable, immutable in nature. For example, like previous hospitalization or history of violence. So let's see in this study, like what are all like patient related factors. Keeping in mind, they did compile in the psychiatric, acute psychiatric wards. So hence the risk factors will be related to that population in general in this study. So the patient related factors are like substance use, craving for alcohol or cigarettes, or a person undergoing a withdrawal symptom. Medication non-compliance is also a factor, and history of personality, uh, bipolar specifically in the manic state, or psychosis symptom disorder. Previous criminal activities is also considered as a risk factor, and history of family violence. There were other risk factors like anger, age, and gender, but they are considered to be having considered as a weak evidence to be considered as a risk factor. And another thing is the patient staff interactions. So, those interactions which lack empathy or respect, which are poor communication, a lack of shared decision making, restrictions of our patients, like limit setting, patients being denied of something. So, these are all like some of the interactions, like patient staff interaction, which there is high chance of getting into an aggressive behavior. Let's move on to the factors related to staff. So, some of the factors related to staff are dissatisfaction with the job itself or with the leadership team, burnout, overworked, tired, having a temporary or unqualified staff, and poor collaboration between staff or the team members. And sometimes, if the staffs are new, they do have increased anxiety in dealing with or working in the particular ward. And the predictive factors related to the ward includes higher bed occupancy, uh, unsafe environment, and basically the busy places on the ward, like hallway. So aggressive incidents were reported in hallways like more like 67 percentage, whereas in a patient bedroom it was only 8.5 percentage. Restrictive environment with lack of structure and inconsistent execution of policies. Now we will move on to another study. This is an observational study which investigated aggressive behavior and use of coercion on an acute psychiatric ward in India. So the key findings of the study states that relatives are identified as the trigger or the provocative factor. Like if you can see the number like 79, that is the amount of that is the percentage or the number of relatives who has identified as a trigger, and they are the common target or victims of aggression, and followed by the staff, the doctors and nurses, are less likely to be the victims. But when they are victims or aggression is towards them, then the use of coercive measures are high. So far we have seen like what are all the different risk factors related in the prediction of aggressive behavior. These are all evidence based studies which also proves us the different factors. Now we'll move on to how to manage aggression. So recognizing the aggressive behavior is so important. So what do I mean by that? Like paying attention to the body language, uh, like facial grimaces, like staring, frowning, body signals like fidgeting or clenched fist, crossed arms, and gestures like finger pointing or chin thrust. So, learning to pick up these cues can help or alert the staff to act better before the escalates. And de-escalation, so response from others can always reinforce feelings. If you are also like showing the anxiety or anger or unsureness to handle the situation, that feeling what you are experiencing will get transmitted to the person. So, and it can make the behavior more worse. So we have to remain calm and de-escalate the situation, and we focus on addressing the individual needs in the interaction can make them to feel safe and less distressed. The third one is like the communication strategies, making a conscious effort to stay calm. It's so difficult when everything around us is in a heightened state, so noisy. But we have to, as healthcare professional, train ourselves to remain calm in those situations. So approach in a warm, friendly, open manner. Avoid confrontational body language and hearing them out. What I mean by hearing them out, um, often when people have like a heightened negative emotions, they cannot rationalize or problem solve or listen to what you are saying. It is important for us to wait for the emotion to recede or go away before trying to respond to the situation or trying to explain to them. So, determining the right time is also necessary to speak. Sometimes silence is a good strategy. Do not pay attention to what they are saying or the words rather than what they are trying to communicate to you. Exploring solutions, try to involve them in decision making. Do not force solutions on them. You need to have them as a partner, and ensuring de-escalation has occurred, making sure they calm down. And if still they don't calm down, then sometimes we have to set limits. So if you find a person's behavior is defensive or disruptive, give them like clear, simple, and enforceable limits. So often, like with the respectable choices and consequences. This is another study which conducted. The aim of this study is to provide a mapping review of non pharmacological interventions that has been used to reduce restrictive practices in adult mental health inpatient settings. So basically, they classified the interventional components using behavior change technique taxonomy. So they identified like 150 interventions, and most of the interventions, like over two-thirds of the interventions, have been classified into four basic clusters. So the like goals and planning. So under goals and planning, we have to make like strategic goals. Look, planning should take place at different levels, like at an individual level. For example, staff working towards reducing the frequency of restrictive practice, like at the ward level and organizational level. Ward level can be like restructuring the environment, like ward or organizational level, like having like reducing the noises, providing like more privacies, having some dim lights, or paying attention to the nature lights, getting some fresh air and stuff like that. And problem solving, it's also considered, or action planning in order to carry out all these behaviors. And the second category in the cluster is shaping knowledge. Um, the most common strategy used was staff training. So, instructions on how to perform a behavior, having good orientation skills, and framing and reframing the concept, like in staff training. For example, like having not restrictive measures and reframing it to more like a trauma informed care, which means like understanding the evolving or reframing the concept of how you want to provide care, having more harm reduction approaches. uh, some having some prompts and cues is also like considered as one of the example for shaping knowledge. The next thing in the category is antecedent. So antecedent is what do you, the word antecedents means like something that happens immediately before a behavior. So identifying the triggers or information about antecedent. Like, for example, if you're not getting enough sleep, automatically you will be tired and aggression is more likely to occur. So, interventions like paying more attention to the overall architecture of design of what can consider as one of the techniques in this cluster. And the last one is feedback on monitoring. So it's highly important, whatever the activities we are doing it, we do have to evaluate it, the outcome of the behavior, whether it was effective in order to what we are trying to achieve. Let's see a video. So far, we have discussed about like what is agitation, and what is the difference between agitation and aggression, different types of aggression, and what are all the different forms, and some of the studies which support like the risk factors of aggression and how are we going to manage aggression using some behavioral techniques. So this video will compile like what we have discussed so far more in a practical situation. And let me know if you cannot see the video.
This brief video is going to describe simple calming and de-escalation strategies. When people are escalated, it often comes from a sense of threat or fear. Even if the threat is not real at the time, their past experiences with people and the world may have wired their brains to expect harm or danger. When we as humans perceive threat or are otherwise incredibly stressed or angry or scared, we activate our survival brain. This more primitive part of our brain has only one job: to keep us safe. It doesn't care about reason or logic. In fact, the thinking parts of our brain turn off and we act mostly on instincts. These instincts include reading nonverbal cues from our environment. Those nonverbal cues are actually more important than verbal cues or what people say to us. So when people are escalated, at their core, they want control. We give them control over their own safety and decisions. Do not block people, corner them, or block entrances or possible escape routes. As soon as you do, they want to fight or flee even more. Give 2 arms length distance. Keep our body posture open so it does not appear that you are hiding anything. Keep your body posture as relaxed as you can, even if it's hard. A looming, towering figure only sends the message that you want to dominate. So if it feels okay to do so, ask them what would make them feel safe or feel better. Put the control back on their turf. Ask what would help. Ask what could happen next. One of the most famous practices and sayings for de-escalation is low and slow, from Teresa Bolick. Low and slow refers to both your body movements and your voice or speech. Just like it sounds, we want to keep the tone of our voice low and the speed of our voice slow. When you lower your tone and speed, it makes it more possible for the other person to process what you are saying and not feel threatened, as opposed to a higher pitched tone and quick speech, which frankly increases stress. Then we also try to lower and slow down our body movements and posture. So try to sit in a chair or on the floor, especially if you were children, and especially if the person who is escalated is lower down than you. Maybe they're on the floor or in a chair. If you get on an even playing field, this gives the nonverbal cue that you mean no threat. And try to slow down your body movements so as to not further alarm their cues for danger. Move slowly, walk slowly, keep your hands out and open where they can see them. Next, use the tip, name it to tame it, made popular by Dan Siegel. By naming emotions, we gain control over them. Therapists have known this forever. Acknowledge that they may be feeling anxious, angry, especially if it's a child. Stay with that feeling, validate it. Let them know the feeling is okay as long as they stay safe. We also like to say, regulate over educate. When people are in distress, it's not the time to teach or educate or think back about what they could have done differently. The only goal is to regulate their emotions. Usually this is done by giving space and time, staying calm, and helping provide a calming atmosphere. It takes the body 20 to 30 minutes to come back down the baseline after a perceived or an actual threat. Just think of your own situations when something really scared you or startled you. Even if you look like you're getting back to normal, your body is still pumping all those stress hormones for a while. So wait it out. Just help people regulate. If the person was aggressive or destructive, especially if it's a child, there does, of course, need to be a consequence. But wait on talking about the consequence. Finally, two of the most important things you can do all along the way, and best before people get too distressed, or even while they're distressed, is to validate their feelings and be empathic. I see you are struggling. I see this is hard. If it's okay, I'll stay here with you until you feel better.
That is a nice video that describes like what are all the basic things we have to keep in mind, like when we are trying to de-escalate the situation. Some of the things highlighted in that video includes respecting the personal space, like keeping in mind your arm distance and how your body posture has to be, like providing orientation and reassurance. is also important. If they don't know where they are and if they don't feel safe, then they are going to act out. And your communication, we talked more about communication, that it needs to be very simple, in a gentle, relaxed, assured tone. In that video, you can see like once they raise the pitch and tone, automatically our mood, even like when we are listening it, we try to get more anxious and anger. Whereas a gentle tone helps us to soothe. Repeat as many time as necessary, like if they are not getting the message because they have heightened emotions, and as it was mentioned, all your flight and fight mechanism is activated, so you cannot, your frontal lobe is not functioning. So that's why it is important that we have to label the emotions, have to bring them back or ground them. In that case, we have to be more like a broken record, have to repeat as many times as necessary. We don't have to get like frustrated. How many times I have to repeat? Yeah, why we have to repeat? We have to understand, because they cannot understand. The body is thinking that they are in a fearful situation, and listen to what they are trying to convey rather than paying attention to what they are saying, like the words. And reassurance. Reassuring the patient that you have understood him or her well is also important. You do all these things, but sometimes the patient can become verbally aggressive. So, how you handle that? Stay calm, maintain a composed demeanor, active listening. Let them express their feelings without interruptions. Don't cut them off or interrupt. Allow them to express or ventilate their emotions. Empathize. Acknowledge their frustration by using, like, and I understand this. This is difficult. Set boundaries firmly but respectfully. I won't tolerate abusive language. These are like some of the sentences what you can use. Redirect, shift the focus. Let's find a solution together. Remember, de escalation requires patience and assertiveness. You try to de-escalate, but there are situations in which the patient can start becoming acting violent. So in that situations, what you will do, warn the patient that violence is not acceptable. Propose a resolution to any problem through dialogue. Offer pharmacological treatment, like giving some PRN medications, and inform them that you will rely on restraint when it's necessary. This is in a situation where they acted aggressively. They started punching, things like that. If there is an imminent danger to self, others, in that situation only you will inform them. But our primary goal is to de escalate before it reaches to that state. This is another video where how the de-escalation skill is used in a healthcare setting. So in this video, you will see two different approaches. And with that approaches, how they are able to de-escalate it.
Someone's been in my bedroom cupboard, and I know who it was, and they took it. I want a doctor.
What's the matter, Ben?
I've been on leave seeing my mum, haven't I, right? And I come back, and I've gone to my wardrobe, and my phone's been nicked. And I know he's taken it. I know he has.
Okay, you're going a bit too fast for me, Ben. Why don't you sit down and take a seat?
I don't want to sit down. I want him to give me my phone back. He's taking it to wind me up.
Who took it?
Philip.
How do you know he took it? Have you got any proof?
I know what he's like. He's always nicking stuff, and I'm going to fucking do it.
Did you see him take it? Did you see him go anywhere near your cupboard?
I've been with my mum, haven't I? I mean, he had 3 hours. That's when he must have done it.
Well, did any of the other patients see him take it? I think we should ask first of all, don't you?
I don't know.
Have you looked anywhere else apart from your cupboard?
Look, he took it. I know he has, and I wanted to give it back. And if he doesn't give it back, I'm going to do him, and I'm going to smash his place up.
Well, let's just ask the other patients first to see if anyone's seen it.
No,
did you take
right.
it home?
I know. He
Let me finish. I was about to say, did you take it home with you?
I didn't take it out.
Look, Ben, you're most probably upset because your leave's over. Lots of people...
No, I'm fucking not. Philip's got my fucking phone.
But you don't know that, do you?
Don't tell me what I fucking know what I've
That's
done.
not what I'm trying to say.
Yeah, what are you trying to say then exactly?
Look, I'm just...
Don't touch me.
Look, calm down.
No, you calm down.
Oh, this is ridiculous. What?
That I've had my mobile stolen. You think I'm lying? Is that it? Is it?
So in this situation, you see like how the conversation between the nurse and the patient has escalated into the situation. What are all the things that the nurse has done which has made worsen, and now they have pressed the panic button. So we will see this is the wrong way of doing it. So now we will watch what is the right way of doing it. What exactly means de-escalation.
Someone's been in my bedroom cupboard, right? And I know it was, and they took it, and I want to see a doctor.
What's the matter, Ben?
I've just been on leave seeing my mum, haven't I? And I've just come back. I went straight to my cupboard, right? And someone has taken my mobile. He's been in there, and he's taken my mobile. I know he has.
So who took it, Ben?
But Philip.
Did you see him take it?
Well, how could I? I was on leave, wasn't I?
Of course. What sort of mobile was it?
It's a Nokia, and it's got a camera. I only just got it.
A Nokia? You must be really angry, right?
Yeah, well, I didn't want to come back anyway, right? But I do, and I see someone's nicked my mobile, right? And I've had it up to fucking here.
Yeah, I can imagine. Listen, why don't we find somewhere to sit down and we can work out how best to get your mobile back, yeah?
Well, yeah, but we can't just sit down. We've got to go talk to Philip.
Why don't you come with me? We'll find somewhere quiet to sit down and talk.
No, we've got to go back. We've got to go talk to Philip and look in his cupboard. He's nicked it.
It's the best thing.
But I didn't even want
to do it quietly.
We need to go and talk to Philip.
Let's have a seat, Ben.
I don't want to see.
Okay, Ben, I'm going to sit down. Are you going to join me? We won't be interrupted here. So tell me what happened.
Well, it's like I said, right? I'm on leave and I'm seeing my mum, and then I come back here and I go at my cupboard and my mobile's got right, and everything else has been like trash. I mean, for fuck's sake, do not muck about with other people's cupboards. It's just wrong.
Quite right, Ben. Your cupboard is yours and yours alone. Listen. This might sound like a stupid question, but I've got to ask it. Are you definitely sure you left your mobile in the cupboard?
Yeah, I don't take it out in case I lose it.
Okay. And you were saying you thought that Philip took it?
Yeah, to wind me up. He's always winding me up.
What made you think it was Philip?
Because I know what he's like.
Okay, have you spoken to him?
I don't know, I couldn't find him.
Okay, we can speak to him later. Did you need your phone now for a particular reason? Did you need to call someone?
No. But my mum might have texted me.
Right. So we need to get your phone back as soon as possible, don't we?
Yeah.
Do you want to call your mum? You can use the phone here.
No.
Okay. So how long were you on leave for?
3 hours.
And was it just with your mum?
Yeah.
So what did you do?
We went for something to eat.
Okay. And what did you have to eat?
What was that? I had steak pie and chips, and then I had chocolate brownie.
Was it good?
Yeah, it was. It was really good, yeah.
So you had a good time then, did you?
Yeah, but it's only 3 hours, isn't it?
Do you wish you had longer?
Yeah, of course.
So how do you feel about being back here now then?
Pissed off.
I can imagine. Lots of people find it quite hard coming back here after they've been on leave.
Yeah. Well, what about my phone, though?
Good point. I tell you what, I don't know if it's right to confront Philip yet, until we've had a good look for your phone. Do you agree?
I bet he done it.
We'll do our best to find your phone for you. First of all, let's double check and make sure it's not hidden somewhere. Is that a good plan?
I suppose so, yeah.
Well, where do you suggest that we look first?
I could take you to my cupboard.
That's a great idea.
Yeah.
So what were you wearing when you went out with your mum? Did you have your coat on?
Yeah, my black coat. Yeah.
It'd be great if it's in your coat, eh?
Yeah, it's not going to be there.
That's a good example of how we have to de-escalate, right? So in the second part of the video, the nurse stayed calm, like took the patient to a calm area, allow the patient to express his feeling. And he was trying to use like validation. And he was also distracting the patient, like by saying like, why, what has happened, like where did he go, like what are the things he has been using. He has taken the time to calm him down, explore a solution with a patient. These are all like some of the techniques what we discussed in theory applied into practical situation, and see how it helped to de-escalate the patient. So in conclusion, detection of these early signs of aggression is so important, and we have to act out, like keeping in mind, de-escalate that. So in that way, we can prevent aggression progressing into violent behavior. And when we are doing it, regular reflection on ourselves is also important, like how we feel in order to handle that situation, and doing a debriefing if the situation has escalated, like doing a team debriefing as well as self-reflection is also important, and reviewing the critical incidents can provide like a learning points for improvement in practice. So thank you for listening to my webinar.